we'll be discussing about neonatal thrombosis, and I'll be presenting the first case for today. I'll be the presenter, Dr. Ankit Jain, and Chinmay sir will be moderating my session. So, coming to my case, this was an outborn baby. This baby was born to a 35-year-old mother with a history of gravida 6, 5 abortions. All these abortions were the first trimester abortions with history of APLA positive status in mother, as well as there was a significant history of gestational diabetes mellitus, as well as preeclampsia and multiple fibroids in uterus in mother. In the antenatal period, this mother, in view of equivocal results for anticardiolipin, but due to bad obstetric history and 5 abortions, this mother was treated for APLA, where she was given IVIG every 3 weeks for the first trimester, the aspirin as an antiplatelet agent, and low molecular weight heparin, that is enoxaparin, for subcutaneous OD for entire conception period. While her gestational diabetes mellitus was managed with only diet modification, she did not require insulin or any oral medication. And preeclampsia diagnosed at 7 months of pregnancy, which was also treated with oral medication. And when this baby came to us, the following history was obtained on referral. The baby was delivered at 34 plus 6 days in view of poor anesthesia on routine checkup. So hence the baby was taken for emergency LSPS. On birth, baby had an ABGAR score of 7, 7, and 8. There was significant respiratory distress at birth, and baby was given CPAP support for 3 days. The umbilical vein catheter, according to the referral report, was inserted on day 2 of life. In view of sepsis screen positive status, where there was a thrombocytopenia, the patient was started on berocolistin and vancomycin. Feeds were started for this baby on day 3 of life, but baby showed poor tolerance to feed, hence the feed was stopped on day 4, and feed was reintroduced on day 6 of life. There was also a history of 2 units of FFP and platelet transfusion outside. Now, on day 6 of life, baby was noted to have bilateral limb changes in form of cyanosis and ischemic changes. And in view of these worsening ischemic or cyanosis changes, baby underwent Doppler study outside, which was suggestive of external iliac artery thrombosis. Hence, the baby was referred to HIMS Dehradun. Baby presented to us on day 9 of life, where on presentation, this was the significant change of bilateral ischemia of foot along with toes. As you can see in the picture, there's a significant bilateral ischemia of both the limbs, especially right more than the left. Along with that, there was early gangrenous changes on 2 of the toes in the right foot. Now, central line was in situ, which on X-ray review from outside, it appeared to have the course of UAC, though the referral card said of a UVC. So a decision to remove it was taken in the emergency itself. On examination of the limb, as I mentioned earlier, to differentiate between arterial and venous thrombosis, baby underwent into examination clinically. There was a clear demarcation line between ischemic changes as well as non-ischemic part of the lower limb. There was no swelling in the lower limb, thus pointing towards less chances towards venous thrombosis. The right-sided dorsalis pedis artery was not palpable, while all other peripheral pulses were palpable. The perfusion index was monitored in all 4 limbs as well at the presentation, as well as for monitoring purpose. We monitored the perfusion index, and it was noted that the lower limb perfusion index was on low from the upper limb comparatively. The upper limb had a perfusion index in between the range of 0.8 to 1, while the lower limb in the right side had a perfusion index of 0.3, while the left limb had a perfusion index of around 0.6 to 0.7. Both the limbs had a low perfusion index, right more than the left. The 4-limb BP was taken, which was normal. A Doppler study was done for bilateral lower limb vessels as well as the abdominal vessels, which showed absent flow in the right external iliac artery, right anterior tibial artery, and right dorsalis pedis artery, while left limb vessels showed normal triphasic waveform in all the vessels. A CT angio was done, which again showed reconfirmed our Doppler findings, which showed a right non-opacification of right common iliac and external iliac artery, with reformation of the right common femoral artery to the inferior epigastric artery. So baby was started on unfractionated heparin after giving a bolus dose of 75 units per kg. Baby was started to maintain maintenance dose of 28 units per kg per hour. And this heparin dose was titrated according to APTT report, though we faced certain challenges. I'll be discussing it later. Samples for the thrombophilic sample was collected. Hematologist opinion was taken for this entire case, and in also on the history of maternal history of APLA, who advised in IVIG and methylprednisolone for the same. The antibiotics which were being given outside, out of which merocolistin was continued and a culture sensitivity was sent, though our HIMS sepsis screen was negative. By day 14 of life, baby started to show improvement, but the gangrenous change persisted. The thrombophilia report had come till now, and it was suggestive of decreased protein C activity, which was around 44%. The lab which we sent to had a normal range of 60 to 140%, but literature mostly mentioned a low protein C value of around 15 to 20% is considered significant, while antithrombin activity was mildly decreased to 77%. The lab values were in the range of 80 to 120%. But we have to remember there was a confounder. The baby was already on heparin infusion when these samples were collected. So heparin infusion might alter the reports of protein C as well as, and especially antithrombin activity. By day 14 of life, the antiplatelet agent in form of aspirin was added to line of treatment. As we can see in next 4 to 5 days, we can see there was significant changes in both the lower limb. The left limb started to become quite well perfused, except the toes, while the right limb, the perfusion of ankle had become significantly better, but the toes were still under perfused or ischemic changes were present in the toes, especially the 3 toes. Now, other investigations done were MR angiography for this baby, which was normal in study, and ECG was done, which was also in normal study. Renal Doppler was done to rule out the renal vein thrombosis as well as renal arterial thrombosis, which was also normal in study. In view of APLA equivocal results in mother, APLA workup for the baby was done, and to rule out antiphospholipid syndrome in newborn, it was also negative for all the factors which we sent. Factor 5 latent mutation was sent along with thrombophilia workup. It was also negative. By day 26 of life, the baby had a methylprednisolone was tapered, and after 3 days of pulse therapy, we gave a 30 mg per kg initial first 3 days. Though there was a lot of controversy, and we did not find a correct indication or a dosing of methylprednisolone and their uses in newborn period and their use of pulse therapy. But according to hematologist opinion, we went ahead with the methylprednisolone 30 mg per kg for 3 days of pulse therapy. Afterwards, baby was taken on low dose methylprednisolone for 1 week, and after that, baby was shifted to oral dexamethasone, which was in a tapering dose for 4 weeks. On day 26 of life, baby was shifted to injection enoxaparin from unfractionated heparin, and mother was taught about how to give injection enoxaparin for the baby. A plastic surgery review was taken for the gangrenous changes in both the toes, who advised for conservative management in view of dry gangrene. Ophthalmology review for the eye changes or thrombotic changes in the eye revealed ROP stage 2 in zone 2 at a single 2 o'clock position in the right eye, while normal vascularization in the left eye, which resolved on its own on the next follow-up periods and OPD periods. By the time day 27, as you can see, left limb had become completely normal, while the right limb had a gangrenous change in the grade 2 and the small gangrenous patch in the second 2. Patient was discharged on day 29 with the advice of tapering dose of oral dexamethasone. The entire plan was explained to them how to taper it, and plan to stop at 6 weeks of life. The tablet aspiration should be was advised to continue at least 3 months of age, which may have to extend further, as well as enoxaparin, which was taught to mother, and which may require till at least 3 months of age, and after that it may have to be continued. A repeat thrombophilia panel plan was considered at 3 months of age. Patient was is advised for regular OPD follow, and vaccination plan was explained to them in view of high dose of steroid was given at birth as well as IVIG was given. So entire immunization plan was explained to them, like post stoppage of a steroid, they may require to give at least 1 month period for giving live virus vaccine, and for IVIG up to 8 to 9 months before giving any live vaccine for the baby. This was explained to the patient. So it was a happy discharge from both the parents, and they went happily home. And on OPD visit on day 35 of life, we can see the right toe is completely, the half of the right toe is completely gangrenous, while the second toe started to improve. And by day 50, this gangrenous change of the right toe had fallen by itself. There was the while the left second toe had improved significantly. So the challenge we faced during the management, heparin infusion dose of 50 unit per kg per hour. Our 4-hourly APTC report was in the range of 30 to 40 only. But since we had reached the maintenance infusion, one of the highest doses, and as well as the baby was showing clinical improvement, we did not increase the heparin infusion further for this baby, as well as the risk for heparin-induced complications like HIT or bleeding was there. That had to be considered while giving the maintenance dose. Second was, as I mentioned earlier, the dose of steroid or dose of methylprednisolone was not clear completely in literature. What dose can be used if we are suspecting autoimmune condition, whether to use pulse therapy or not to use pulse therapy in these type of cases. Third was, there was since there was an initial period, there was a hesitance for the compliance in the mother. We went back to literature and found that there is still oral anticoagulants are not very much available for the newborn, and only 6 oral anticoagulants are under different type of clinical trials, like for factor 10 inhibitors in form of rivaroxaban, apixaban, edoxaban, and betrixaban are the factor 10 inhibitors, while factor 2 bivalirudin and dabigatran are the 6 total anticoagulants which are under different phases. Like all the 10 factor 10 inhibitors are in the range of phase 1 or phase 2 trial, while the most advanced is the bivalirudin, which has been used in certain cases, and there were studies of usage of bivalirudin under 6 months of age also, in the doses, different doses of 0.125 to 0.25 mg per kg, but still it is not completely into the market. Dabigatran is the second one which may come to the market because it is under phase 3 of trial. But all the other factor 10 inhibitors which we are being commonly used in adults have are under various stages of trial for the newborns. There was again a second fourth dilemma we had faced was whether to go ahead with thrombolysis or not to go ahead with the thrombolysis in the baby. But since the baby was showing significant improvement in form of ischemic changes and being in better perfusion index day by day, which was being monitored objectively for this baby, we chose to not go ahead with thrombolysis. As well as we need to consider whenever we are going for thrombolysis, there is minimal data which exists in newborn population regarding the thrombolytic therapy, about its indication, safety, efficacy, what agent should be used, what is the duration of therapy, whether what will be the monitoring guideline, as well as the technical expertise is a challenge for a neonatal thrombolytic therapy. But it was definitely considered since the baby was improving clinically. We did not go with thrombolysis in this baby. And fifth, which is one of the most common problem as we all face in our daily life, is the cost of thrombophilia panel, which is quite high, 15,000 rupees, as well as monitoring of factor 10A, which is recommended whenever we are giving the low molecular weight heparin. The availability of this test is also low, and wherever it is available in India, it is costing around 8 to 10,000 just for monitoring factor 10A level. So these were the one of few challenges that we faced during management. What will be what will you should take home as a message? The central lines are the most common reasons for the neonatal thrombosis. Uses of diluted heparin infusion is important and for USC umbilical arterial catheter to prevent catheter blockage and to reduce to a certain number of thrombosis cases. Early identification of all the cases of vasospasm and thrombosis of immediate removal of central lines are important, as well as looking at the force of UVC, UAC, and deciding where your line has gone and monitoring them. In cases of non-improving cases, thrombolytic therapy may be considered in neonates. Thank you.